So in this talk, I guess many of you have heard about our disease trajectories before. So the focus will actually be on some new work that we published a few weeks ago on prescription trajectories, where we've taken a lot of data to see how people follow prescription patterns when we take data from a 25-year period. So this is from an older review, just illustrating this point. We're interested in the rewiring of networks and how variants and exposures impact the rewiring of networks that lead to disease. But it's the right side here. How do we keep track of the comorbidities? What is the temporal order of comorbidities and all that? This is what we try to work on, and we've worked on that for a few years, trying to finding out what is the order of the diseases. And I guess also many of you have seen this before. We also have this big arrow over here with the exposures that we now have switched to, because of course some of these diseases you get, they are also treatment provoked, especially when we have elderly people with a lot of diseases and a lot of polypharmacy effects. We are trying to go into that, and then of course track it back to molecular level biomarkers. So the exposures, this is what we now focus on, drug combinations, drug cocktails, and that's also why we look at data from millions of people, so that we can get good statistics for that. So there's a little bit of lag here, but maybe I should go over here. So the idea is to make these trajectories and stratify patients in subgroups, not from one diagnosis, but or prescription, but from the longitudinal pattern over many years. And we published a lot of papers on that, on the disease trajectory sides, and I will just flash them. Here's one from sepsis, where we could resolve some controversies in the literature about what the relative risk was in relation to dying from a sepsis diagnosis. And it turned out that if you sort of subdivide patients into different subgroups with different comorbidities, it all makes sense. But in several papers, they just put everything together. So we've done a lot of these trajectories where we try to follow not disease co-occurrences, but disease progression patterns. So when you see two diagnoses in such a graph here, there is a statistically significant progression pattern where patients predominantly go in one direction. So it's not just disease co-occurrences. And the reason why I also mentioned that is that this one is a little bit, I need to get familiar with it, but some of you might also have seen that we published this browser where you can make your own trajectories. So this is the website, and this is the publications. It doesn't really seem to move here. Lasse, what's wrong with your
No idea.
But that's good for you, because then we save some time. But I mean, you plug ICD-10 codes or text into this browser, and then you will be able to make these. So I just wanted to highlight that. Back to the polypharmacy, because that's the new story here. So you saw a lot of colors on the ICD-10 codes before from the different chapters. So when we move to drugs, we run out of colors. So we in some sense reuse the colors, but now it's reflecting ATC groups, and you see them here. And this paper starts by making statistics over time and age here, where you see for males and females how we use our drugs. If we take the entire Danish prescription registry, and you see we get a lot of drugs when we are babies, then it goes away, and then it comes back, and some differences between the two sexes. And you, for example, see more drugs obviously here with sex hormones and so on for females than you see for males. So this is sort of 7.2 million individual prescription trajectories, and we try to condense them and try to find the highways in prescription space. Just taking thus one type of exposure into account. So we have around 1.1 billion prescriptions in this data set, and we have used a large supercomputer to analyze it. But of course, a lot of drugs, more than 1,500 drugs, and more than 575 unique chemical subgroups. So our approach is that we try to make this computationally tractable. So we see if you take one drug group and see how does that increase the likelihood that you will get another drug as the next prescription. So it's fairly simple, but the whole computational setup is very complicated. But you see a lot of drug groups here, and you see a lot of red cardiovascular groups and so on. But all these pairs here, they are statistically significant, and they are sorted according to the mean average time between them. And then, of course, you can look at some of these pairs where you switch one from one HCC group to another. You can also look inside one HCC group and see how people change between first-line treatment and second-line treatment and third-line treatment. This is, of course, interesting, especially in precision medicine, where you might want to start up some patients on second-line treatment and drop the step with the first-line treatment. So this is the idea. So the statistics here is reasonably simple. So what is coming out of that is a lot of highway prescription trajectories, like we have seen them with the disease trajectories. And if we, for example, say we want to see all the statistically significant trajectories of a certain length followed by more than 1,000 patients, we get 9 million of them. And that's, of course, just a threshold. If you say 10,000 patients, you get a lower number. So this is just a starting point for analysis, sort of mapping all these statistically significant progression patterns in prescription space. So one of the case stories we have in the paper is hypertension. And so now we are inside one HCC group, and we see how patients sort of follow different subgroups in this space. And the first line treatment is often ACE inhibitors. Then some patients switch to angiotensin II receptor blockers, ARBs, as second line treatment, and we can follow that. So we made a case story on that. We took all the patients that got these two groups of drugs, and then we compared those who just continued on ACE with those who just go on ARBs with those who actually switch. And the first thing you can do is to make a survival analysis. And it's quite interesting that those patients, and you can see we have a lot of patients here because it's a frequent disease, hypertension, and there are many people with prescriptions with that indication. So we are having 500,000 with ACE and no change and so on. So these numbers are quite large. And you see those who are on ACE here and do not change, they live shorter than those who, for example, start on ARB. That's the one in the top. Start on ACE and switch to ARB. That's the light blue. So you see differences in mortality here. So what we then did was to go to UK Biobank. Much smaller data set. It's only 500,000 people. This data set we have 7.2 million. But of course, in the 7.2 million data set, we have also nice biobanks behind the blood donor study. We have the Copenhagen Hospital Biobank and so on, so we can make genetic analysis there. But that will follow. But we started with the UK Biobank. But we saw more or less the same pattern here. The mortality in completely different healthcare system is highest for those who just go on ACE. And there's Also a lot of censoring and so on that I will not go into in this short talk. We've made the statistical analysis together with Lars Mortensen from Statistics Denmark. So it's reasonably solid, I would say. But once you have these groups, then of course you can make GWAS analysis, and this is what Alejandro, who's the first author of the paper, actually did. And if you compare these two groups, then it's interesting that it's actually two hypertension-related genes that pop up. But this analysis is not finished or anything like that. It's just to illustrate the point that we get a kind of a complicated, in this case, we just switch from one drug to another. But of course, with these prescription trajectories, we can make quite complicated phenotypes that actually might, that's something Ross Altman, for example, have shown in previous analysis, that the switching of drugs actually to some extent reflect your genotypes. I mean, doctors switch drugs because it doesn't work or it gives too many side effects. But Ross Altman has shown that in some cases, doctors actually change the drugs to something that is compatible with the genetics, but without knowing the genetics. And I think that's quite interesting. But of course, knowing the genetics up front, then you can save the patient and the society for a lot of trouble. So that's, of course, the way forward. That is to combine these longitudinal phenotypes with molecular level biomarkers, not just phenotypes, but of course also protein QTLs and many other things that you can bring into the picture here. So what we actually think we can do, and I will also just mention this quite shortly here, is that we actually think we, just from the prescription data, can identify many of the patients that actually should shift away, for example, from ACE inhibitors. So what we do is essentially to say, we imagine that we, of course, this is retrospective, that the patient is diagnosed with hypertension. Then we look at the previous prescription pattern that might not be hypertension related, of course, because this is a newly diagnosed patient with hypertension. And then we saw that 31% of the patients treated with ACE alone are more similar to ACE with change to ARB in their previous prescription history. So we think just by using this one data type that we actually can identify them without phenotypes just from the previous prescription history they have had, at least maybe if we really try to have few false positive and negatives, we might just go for 15% of them and take the most top ranking patients that actually likely to switch. But in order for this to be critical, of course, one needs to do it's foregoing clinical trial, but you get the idea that there's a lot of information that also reflect your genetics in how you switch back and forth in terms of efficiency in relation to the genetics, but of course also something that relates to risk phenotypes. So this was prescription trajectories. We also had another paper in revision where we took this a step further, namely into dosage changes, because one thing is that you switch from one drug to another, but and that was done on the Danish patient registry that we showed you the statistics for. But we also have these large data sets where we have raw and complete patient records with all the data and all the dosage information. And we have made a paper on part of those data where we have data from 1 million patients. And we have 24 million prescriptions here. And there's, of course, a lot of polypharmacy in these in-hospital data. And you can see how it actually breaks down in relation to the ICD-10 chapters in terms of of diseases. And not surprisingly, the more prevalent the therapeutic group is, the more it is co-administered with other drugs. It's not so surprising. So, but we made a sort of treatment episode model where we can follow the dosage changes. Here you actually see 2 drugs, just to make it very simple. This model actually is 5 slides long, but we try to track all these dosage changes that are indicated by different colors here, and then we define treatment episodes, and then we see when the combination of drugs correlates statistically significantly with dosage changes. And what is coming out of this is a lot of co-medication pairs that change dosage, where you have an index drug and then you have another drug, and then the dosage of the index drug is changed in a statistically significant way when co-administered with the other drug. And then we get around 4,000 pairs with significant dosage changes. So the story is longer, but it's just to highlight that we can also make dosage trajectories, how dosages change over time. But what we did here was to try to see if we pool a lot of databases with known drug-drug interactions, all these pairs that we find that actually are changing or provoking dosage changes when they are co-administered, how many of those are similar to what you can find in drug-drug interaction databases. And then it turned out that, here you see the ACC groups again, that 83% of these 4,000, actually for those 83% we could find known drug-drug interactions. And for the 17%, a little bit hard to see here, we couldn't find any DDIs, but we could also see that these groups had lower patient volumes, and they were also less described together in the literature. We did a lot of text mining of 15 million papers, and they also had higher odds ratio. So presumably they might not have been discovered because the patient groups are smaller. At least that's what we suggest in the paper. So my point is here again that we should maybe, if we're interested in disease progression patterns, we should try to make more systematically longitudinal phenotypes in this way, using the data we have that is picked up over so many years. And now we try to move away from these disease trajectories over to some exposures with the drugs and make prescription trajectories. And of course, the next step will also be to put it together to find out which diagnoses are likely treatment provoked. And for that, this data set will also be very useful because we can text mine all the text in the clinical notes and identify side effects like we have done before. But this is the perspective in this work. I'll just also end by mentioning some work we did with Anders Perner on intensive care patients some years ago. We are now also submitting a third paper, but it's not so much to get into the intensive care area. It's more the predictive value in longitudinal data. And here we predict mortality for intensive care patients, and normally you compute, for example, SAPS scores. You monitor the patient for 24 hours, and then you produce SAPS2 or SAPS3 mortality scores. So what you also can do, of course, with these acute data from 24 hours is to take the disease history, for example, from 15 years. Yeah. And then you can plug them into an old school neural network, machine learning algorithm. And then, of course, you can compare. What was interesting here is that if you take the history, the disease history at admission, then it's slightly better than what you know after 24 hours with a SAPS2 score. And of course, the score from the disease history, you can compute it when you roll the bed into the wall. But by putting them together, it becomes, of course, much better. So there's a lot of predictive value in these disease trajectories, and then can be, I think, hooked into all kinds of predictive schemes, and you also see others in Denmark working along these lines, but it's mostly done as disease co-occurrences. If you take a Charlson score or something like that, there is no progression pattern built into it. So the new aspect is that we only take those disease trajectories in that have a sort of statistically significant progression pattern. So I would like to highlight that, and there are some details in it that I have no time to get into. And this is a neural network, so you can also do explainability and find out what features are important. But my main point here in this talk is to say that with all the biobank work and all the samples, we need to attach some more complex phenotypes to them so that we can look for biomarkers that relate to these more complex phenotypes, quantitative phenotypes with dosage changes and so on. And we can get much more out of the sample. This is my message. And we also in my group work a lot on adverse outcome pathways. There's a review here from a few years ago. So we are not just into exposures in the form of drugs, but also pollution and chemicals from the environment. Of course, you can do similar things with them if you have them tracked down over time. But we didn't used to work on the non-molecular side of things, but now we work on that because we would like to find biomarkers that are sort of biomarkers for new phenotypes rather than just sort of more simple ones. Other people are better at doing that compared to us. So this is the group, and thank you again. Here's some extra acknowledgements, but you saw the papers also cited, not some slides.